Welcome back to Open Med School. And Dr. Andrews, Professor of Medicine and Consultant Neurologist. This is part of Neurology Simplified. I'll be discussing Anosognosia. Start with a case. This is a history of a 68-year-old woman admitted with a left hemiplegia. She denies any problem and becomes irritated once she is helped because of the weakness. What is your likely diagnosis? So here you can see the infarct in the MCA territory, right MCA territory, with a hemorrhagic transformation of the infarct. Anosognosia is a neuropsychiatric condition in which the person is unaware of their disability. This was first described by Joseph Babinski in 1914 in patients with the left hemiplegia, that is, right-sided brain problem. Often, this is due to lesions in the right parietal cortex, and stroke is one of the leading cause. But this can also occur in lesions in other areas like thalamus, basal ganglia, temporoparietal region, and even on the left side. Psychiatric disorders may also present with anosognosia. That is why it is said it is a neuropsychiatric problem. Pathologically or pathophysiology, the patients may deny hemiparesis, memory loss, or language deficit. Any deficit can be denied. Often, there is somatosensory neglect, that is asomatognosia. Asomatognosia means the patient denies that side. That is, the patient will say that that side doesn't belong to them. So there will be neglect of, can also occur. This is also part of a right parietal lobe lesion. As mentioned, stroke is one of the major cause, but neuropsychiatric problems, schizophrenia, around more than 50% of patients can have anosognosia and 40% of patients with bipolar disorders. In minimal cognitive impairment MCI, 60% of patients and more than 80% of patients with Alzheimer's disease also has got anosognosia. So it is not limited to hemiplegia. Clinical evaluation, bedside interview is the essential thing. May require conversation to uncover the problem. Sometimes there can be confabulation, especially when patients with dementia or other mental illnesses. Confabulation is a lapse in the memory which is being replaced by something from the past. This is classically seen in Wernicke's encephalopathy. The neuroimaging findings depends upon the etiology. Usually in the stroke it is the right parietal or temporoparietal problems, infarct, sometimes thalamic lesions, basal ganglia lesion, and even left parietal lobe lesions. Dementia usually get global atrophy. In psychiatric conditions like schizophrenia, non-specific changes. Treatment and management, there is no specific treatment. Cognitive therapy may improve the problem and give some compensation. Differential diagnosis, denial, psychological defense mechanism in encephalopathy may also be confused when there is delirium or there is a lack of attention or impaired wakefulness. Other deficits like visual problems, cognitive impairment or sensory limitations may also be confused as anosognosia. Prognosis may resolve over time after stroke. In dementia and many psychiatric conditions, this may be persistent. And presence of anosognosia is associated with the lack of compliance to treatment and delayed presentation to the doctor. Hope anosognosia is clear to you. So anosognosia is denial of illness. Patient is unaware of the deficit. Hope it is clear. Thank you.